speakers of our extracorporeal, associates, PGs, and invited guests. It gives me great pleasure to introduce Dr. Brigadier Ranjit Nair. I acknowledge his presence in our group. To introduce you, I have already given a note. He is the national coordinator for the DPNB students, and he was kind enough to send our link to all the national level PGs so that, he has opened his video. You can see Ranjit Nair. So he is in our expert panel. Anytime you can give your comments. He's a good teacher. I recently got acquainted with him, and he's doing a wonderful job connecting so many students and doing teaching, taking the help of many speakers. And I told him that we have good speakers in our pool. He can take their help too. He is associated with Gangaram for the bedside teaching for the national level DPNB students, and now with us with our experience sharing our meeting. Thank you, Dr. Srilada, Rajapurkar, Jacob George, who are all great teachers in our group, and also the other members of our speaker pool, ladies and gentlemen. So today we have a very important session, and can the host mute all except the one who is speaking, please, Nana Sahib?
Yes,
so yes, please. And today it is my pleasure to introduce Arun Thomas, who is the professor at Believers Hospital. He is a very good academician and very innovative in so many things, and he is introducing it in the mid Kerala, and he should become a role model for many junior consultants to be emulated. So he gives a good support to our extracorporeal, and thank you, Arun Thomas, for that. And with this short introduction, may I request Arun Thomas to take over to introduce the subject and to introduce the speaker, Martin. Arun Thomas, please.
Good evening, everyone, and thank you, Georgian Nainan sir, for this wonderful platform. Monday evening is always very exciting for all of us because it is going to be always an academic feast, 1 hour, 9 to 10 p.m. Monday. And now today is a very important, very relevant topic in our day-to-day practice, clinical practice. This is on ADPKD, and we have Dr. Martin here for discussing the topic. And Dr. Martin, I know Dr. Martin for the last 10 years. From the time he was doing MD General Medicine in Calicut Medical College, he is always an academic enthusiast, and he always dissect out the literature and academics and take out the best clinical pearls from it. And hopefully Dr. Martin will be sharing it with us. And he, after MBBS and MD General Medicine from Government Medical College, Calicut, and he pursued his DM nephrology from prestigious Stanley Medical College, Chennai. And now he's a consultant nephrologist in Malabar Hospital, Calicut. And Dr. Martin is always an academic enthusiast and also very keen for intervention nephrology. And for today's topic, this is ADPKD, and I will say this is one of the best topic that should be discussed in this platform, because we have to dissect out the literature and take out the best clinical pearls based on the evidence, and you have to discuss with the senior faculties here how to implement in our clinical practice. Because in older days, we just watch the progression of the ADPK to end stage. We are not intervening. We are just hydrating the patient maximum. We may be using some RAS blockers. Now we have a tolvaptan with a lot of good evidence from the clinical trials, but we are in a gray area. How to translate this evidence into clinical practice? Like in the trial, they used a very high dose of tolvaptan. Is it practically possible in our population? And the endpoints, till how long we have to continue the tolvaptan. The trials, they stopped after a few years, but how long we can continue, because ADPKD is going to be a lifelong disease. And do all patients need a tolvaptan, or should we pick up the selective patients with a high risk? So a lot of gray areas. We need to dissect out the literature, and we need the experience sharing from our senior faculty members so that we can translate everything to our clinical practice. So I request all the participants to keenly attend the topic and take part in the discussion so that we can make a significant difference in our clinical practice. So over to you, Dr. Martin.
Thank you, Arun sir, for that kind introduction. First of all, let me thank the extracorporeal group for giving me this opportunity to present. So straight away going into the topic. preventing progression of ESRD in ADPKD patients. So we know that autosomal dominant polycystic kidney disease is the most common monogenic kidney disease that we have, and it's the most common inherited cause of CKD as well. By 60 years of age, 50% of the patients have already reached end-stage renal disease. It's very frightening. And you can see by the photos that the kidneys are completely replaced by cysts in the cortex as well as the medulla. And these patients develop hypertension and finally turn up as end-stage kidney disease in our dialysis units or in transplant programs. And world over, 5 to 10% of such patients end up in ESRD. Looking at the Indian scenario, depending on our 2.6% of the patients in our CKD registry in India, which was published by Rajagopurkar sir in 2012, had ADPKD. And a study from Shimla with IGNC Shimla showed that they had a cohort of around 208 patients, which they studied and monitored how they progressed. And many of the times these patients had a higher age and diagnosis was high, and most of these patients had already had renal dysfunction at the time of diagnosis. So genetics, we know that the most common 78% cases of ADPKD are due to mutations in PKD1 gene, which codes for polycystin 1, and it's located in the short arm of chromosome 16. And 15% of the cases are due to a mutation in polycystin 2, which is coded by PKD2 gene, which is in the long arm of chromosome 4. And both these molecules are part of the primary cilia, and they act on the mechanotransduction as a mechanotransduction organelle. And there are other genes also which are described, GANAP, DNAJB11, and others. And there is a mutation where the tuberous sclerosis gene, which is very close to the PKD1 gene, both can together get deleted and can have presentation as a very severe phenotype. So here we can see that this is the principal cell of the collecting duct. We can see that this is the tubular lumen, and here is the primary cilia. You can see that the polycystin 1 and polycystin 2 are located at the primary cilia. And they look like this. The polycystin 1 is a large molecule which extends outside transmembrane part is also there. And the polycystin 2 acts as an ion channel for calcium. So when these two molecules are functioning properly, there is no cyst generation, there is no fluid secretion. But when they are mutated, or when the post-translational modification area is mutated, for example, the N-glycosylation and endoplasmic reticulum area where genes are involved are mutated, you get a defective gene. And whenever there's a defective gene, there is a decrease in calcium levels in these principal cells. There is increase of CAMP levels, and this leads to increased fluid secretion and cell proliferation. Another interesting thing regarding the genetics is that the PKD1 truncated mutations show a very severe phenotype where ESRD is attained at 56 years of age. But PKD2 mutations, they are milder in severity. Here you can see the survival analysis of all the three mutations, the PKD1 truncated, PKD1 non-truncated, and PKD2 mutations, where PKD1 truncated is the most severe one. So whenever we have a patient with cyst, if the patient already has the family history of ADPKD, then things are usually easy. We can apply the unified criteria for ultrasound diagnosis, where there are definite criteria set for diagnosing predicting the possibility of ADPKD. But the problem arises when there is no definite family history of ADPKD in the family members. Then you have to keenly dissect out each aspect. You have to look for other features. For example, if the patient is already stage 4-5 kidney disease and already having a small kidney, then you have to think about other cystic disorders like an acquired cystic disease. When you have very few renal cysts but lot of liver cysts, you have to think about ADPKD. When there is congenital hepatic fibrosis, you have to think about ARPKD. When there are other extrarenal manifestations in the form of tubers, facial angiomas, you have to think about tuberous sclerosis complex. When there is an association with pheochromocytoma or renal cell carcinoma, you have to think about von Hippel-Lindau. And like that, there are some other cystic diseases which are similar. But when you are having a patient with renal cyst and there is no family history of PKD, but the cyst, both the kidneys are bilaterally enlarged, and more than 10 cysts are seen in ultrasound, you can conclude that it is a likely case of ADPKD. At the same time, if the kidneys are not enlarged, then again you are in trouble. You have to look for different criteria, but the uncertainty persists, and whenever you have a real doubt of whether or not you are dealing with ADPKD, only genetic tests can help. So we usually think that ADPKD is a simple diagnosis. So here I have projected 4 patients, and some of them even have a positive family history. Can you tell me how many of these patients are having ADPKD? Looks very familiar, very similar. The number of cysts are also high, but you can see that the kidney sizes are not that big. Actually, none of these patients are having ADPKD. So you can see that as years progress, the importance of genetic testing is coming up. And in atypical cases, and when there is no family history, or when you are working up a donor, and when you are doing a pre-implantation diagnosis, or when you are doing a prenatal diagnosis in the form of a chorionic villus sampling, genetic testing may be indicated to look for whether or not you are dealing with a ADPKD pathological variant. Now, once diagnosed, you are strapped with cyst-related complication, extrarenal complications, hypertension, and by 5th or 6th decade, the patient ends up in end-stage renal disease. And then you can see them on your dialysis list or on your transplant list. Whether something can be done about it, that can be decided on what drives ADPKD to end-stage renal disease. We know that it is the deficiency of the polycystin 1 and polycystin 2. It can be due to mutations, it can be due to post-translational modifications. But ultimately what it does is it changes some milieu inside the principal cells, a decrease in calcium levels, an increase in CAMP levels, increase in mTOR levels. But these are all intracellular events which we have no control of. But that is when we lay down our eyes on this molecule which acts from outside the cell, which perpetuates the cystogenesis. So whenever this vasopressin molecule in the predisposed individual, when the vasopressin molecules, vasopressin levels are usually high in ADPKD patients, when they act on the receptors, they increase the proliferative tendency, they increase the fluid secretion tendency, and causes disruption from the main tubule and cause cystogenesis. So the problem is, though we have a molecule like this, the cost, we know that the cost of the molecule is high. The side effects of this molecule, especially the aquaretic effects, are intolerable for many patients. So how will we choose? So it was always a matter of a search to find a suitable marker to prognosticate ADPKD patients. The usual one which we started with was serum creatinine and EGFR. But in CRISP study, they have already shown that renal failure and the rise in serum creatinine, etc., occurs only by 4th or 5th decade. Meanwhile, the kidneys have already enlarged massively, producing size problems, pressure problems, cyst-related complications. Everything might have occurred even before the serum creatinine have risen. And we know that many of the patients will be already suffering from hypertension and other related events caused by ADPKD before the creatinine starts to rise. So creatinine and EGFR decline are late prognostic markers. We can't depend on them. But the CRISP study suggested another interesting prognostic marker. That was total kidney volume. So let me please look at this A diagram. Here you can see that these 3 lines are trajectories of 3 patients. For each patient was analyzed with imaging modalities at different points of their lives, and they found that in each patient, the increase in total kidney volume per year is constant. In this patient, it is high. In this patient, it is moderate. And in this patient, it is low. So when you look at the total kidney volume over the years, the patient with a higher rate of increase in total kidney volume will have a very large kidney size. And when they correlated it with the EGFR, they found that these patients who have very high rate of high rate of increase of total kidney volume, they did very bad, developing ESRD very early in their lives, not early, by the 5th or 6th decade of their life. So they found that this is an interesting biomarker which can be used. But the problem was serial imaging. For that, they brought about a new thing called height adjusted total kidney volume and age at the time of imaging. So with this, with a single imaging, you can classify patients. So how did they do it? They measured the different dimensional aspects using an ellipsoid equation. It was the sagittal length, the coronal length, maximum depth, and width were measured, and it was put into the ellipsoid equation. And with that, we could find, calculate the total kidney volume, and from that, by adding the patient's height and age at the time of that particular imaging, we could calculate height adjusted total kidney volume of that particular patient. Because based on this, we could classify these patients into 5 groups. Class 1A, Class 1B, Class 1C, and you can see that the Class 1E patients had a maximum rate of progression of total kidney volume, more than 6%, and the Class 1A had the least. So obviously the upper classes are the ones which are having rapid increase in kidney volume. When they analyzed it with the help of EGFR decline also, they found that the 1E and 1D and 1C, these were the people who were having steeper EGFR decline over the years. So if you have patients, you can, by calculating the height adjusted total kidney volume, you can put them into certain classes. For example, the first patient who is having a GFR of 97 but a TKV of 222 can be classified in Class 1E, which is a very rapidly progressing disease. And at the same time, the patient 1 can be put into the Class 1A, and patient 3 will be having a rapidly progressive disease. So based on these parameters, we could classify which patient is going to do bad or which patient is going to be stable with no much progression of kidney disease. One more thing was found while doing this classification. They found that a special group called an atypical ADPKD was also described. Atypical ADPKD means the cyst formation occurred either in a unilateral kidney or in the segmental part of a kidney, or maybe asymmetric. One kidney may not be fully involved, the other kidney is well involved. At the same time, it can be lopsided, where there are exophytic cysts, large cysts which are protruding out of the kidney. And there are also situations where they saw in some cases the kidneys were so shrunken that they had to be classified differently. So these are atypical forms of ADPKD, and when they studied, these were not having that bad drop in GFR, and these patients were relatively stable over the years. They also developed another scoring system where they incorporated some clinical features and as well as the genetic factors, that is pro-PKD scoring system. Here, based on these parameters, they could classify patients into 3 groups: a low group, intermediate group, and a high group. And the high group was found to have rapid progression. So by this time, there were studies going on tolvaptan, and the tempo 3:4 study came in. By that time, the Mayo classification system and the pro-PKD classification system has not established yet. But for this was a study where they initially used tolvaptan for the ADPKD patients. Here they classified patient based on the creatinine clearance of more than 65 and total kidney volume of 750, where this was considered as a bad prognostic indicator at that time. And when they studied the 2 groups, they found that the total kidney volume per year increase was lesser, 2.5% in tolvaptan group, and it was only 5.5% in the placebo group. And there were adverse effects in both the groups, but they were comparable. So that was the first evidence of tolvaptan being used in ADPKD. The study went on for 3 years, And after 3 years, the results came. But the problem is the US FDA still wanted to know whether it works for patients who are having a lower GFR. Here, the GFR was more than 65. They wanted to know whether this worked in patients with lower GFR. That is when the next study called the Reprise study came in, where they found a cohort of patients with ADPKD who are having an EGFR of 25 to 65. The special thing regarding this study was these patients had a run-in period of tolvaptan, where almost 8 to 12 weeks were used to see whether these patients tolerated the drug better. And only then were the patients randomized into the groups and seen. Here also, tolvaptan scored better. It was found that around the drop in GFR was only about 2 to 2.34 ml per minute per year in the tolvaptan group compared to that of the placebo, where it was higher. So by these two studies, there was strong evidence for the use of tolvaptan, but more analysis had to come. The problem was there was no definite guidelines by that time. A few countries like Canada, US, and Europe put forward certain frameworks through which they worked. And in these frameworks, this is what they found. They planned. They recommended that an age of 18 to 55 with an EGFR more than 25, and the Mayo class 1D and 1E, and Mayo class 1C only if there is other evidence of rapid progression, and a ProKD score of more than 6, annual GFR decline of more than 3. These were considered as features of rapid progressors, and they thought that these were the patients who will be better off benefited when treated with tolvaptan. And based on the two studies of Tempo and Reprise, they tried to analyze how much lead years a patient got. For example, and two things that they found is when the drug was started earlier, the lead time that the patient got was more. For example, if this patient who was having an EGFR of around 90 was not treated, then would have ended up in end-stage kidney disease in over 20 years. But when treated, he gained almost seven years ahead of him before he reached ESRD. Similar was the effects in other groups. So whenever it was started early, the lead years that the patient received were more. Whenever the drug was started late, when CKD has already set in, the lead years were less. And both the studies, it was comparable, but there was mild differences. The next thing is how to dose a patient who we plan to treat with tolvaptan. So 2 doses are advised, one large dose upon waking up and another smaller dose 8 hours later. There were 3 available doses available, 45 milligram in the morning, 15 milligram, or 60-30 or 90-30. And the initial starting dose was later slowly titrated up to the maximum dose of 90 plus 30. The problem is many patients were not able to tolerate, so there were many dropouts, but still a significant number of patients continued the drug, both in Tempo and Reprise. Though the dropout percentage was high, there were a significant number of patients who continued the drug without much problem. And why this 2-time dosing, one in the morning and another in the afternoon? The night dose is skipped because to prevent nocturia to the patient. Tolvaptan had its own problems. The side effects were not that good. Aquaretic side effects, renal side effects, gastrointestinal side effect, of which the aquaretic side effect and the gastrointestinal side effects of hepatotoxicity were concerning. The hepatic side effects were mainly due to the T cell activation, oxidative stress, and cholestasis, which happened by the drug, which were caused by the drug. And because of this reason, close monitoring of the liver function test upon initiation fortnightly for the first month and monthly for 1.5 years, and 3 monthly thereafter was advised. So you can imagine how the patient should be constantly under the watch with multiple blood investigation throughout the period the patient is on this particular drug. And the thirst, polydipsia, dry mouth, and dehydration can be distressing for some patients. So whenever starting a patient on tolvaptan is decided, we have to discuss these matters with the patient. And if a patient is having an occupation where access to water, access to bathroom is questionable, for example, for people who are working at in shifts in different places and all, they are not allowed, they are not able to get access to these. So, so prescribing these drugs to such patients may not be ideal. And also the up titration must be slow so as to give the patient's body the time to adapt to the aquaretic side effects the drug produces. And if there is aquaretic side effects are severe polyuria, severe thirst, and the patient is not able to tolerate, then you are always welcome to down titrate to a lower dose and decide. But whenever you have a scenario where 20% or more reduction in GFR is observed, we have to stop the drug. And if you are not able to hike the drug higher because of the side effects, the another thing that we could try is to check the urine osmolarity and make sure it is less than 250. And all these patients should be advised a high fluid intake up to 2 to 3.5 liters per day. And just like our SGLT2 inhibitors, 6-day rules applies to this drug also. This drug is contraindicated in pregnancy and breastfeeding. So young females, contraception is advised. At the same time, CYP3/4A inhibitors should be avoided. And regarding drug-induced liver injury, about 3 to 4% were observed in the trials, and all of them usually occurred in the first 18 months of the trial. And if there is a rise in enzymes more than 3 times the upper limit of normal, or if there are signs of liver failure, there is better to permanently discontinue. And if the enzymes are less than 3 times upper limit of normal, rechallenging at doses with close monitoring will be required. There were other drugs other than tolvaptan which were tried. You know that SGLT2 inhibitors is used now everywhere, but that was not found to be effective in ADPKD progression prevention. So was metformin, mTOR inhibitors, pravastatin, and the tyrosine kinase inhibitors. Somatostatin analogs, there was some discussion regarding it because even though it didn't reduce the slope of eGFR and time to end-stage renal disease, it had some action on reducing the cyst size of the kidneys. So in patients who are having severe discomfort due to cyst problems, cyst size and pressure problems due to cyst, and who are not tolerating tolvaptan, and there are no other options other than surgery, and the patient is not keen on surgery, somatostatins analogs could be tried. There was a discussion, but still definite guidelines has to come. Now, apart from the drugs, there are some basic things that should be always followed when treating ADPKD. That's the blood pressure control. AC inhibitors or ARBs are the first line. And a target of less than 110/75 is suggested by a study called Heart PKD trial. But the problem is while going so low on the blood pressure, the chances of AKI is also increased. But the good thing is when you have good control over the blood pressure, the chances of intracranial aneurysm rupture or growth has also comes down. Also, it has an effect on reducing the ventricular mass and albuminuria. For patients more than 50 years of age, the SPRINT trial or our KDIGO guidelines could be used with a systolic BP of less than 120 or 130. Protein restriction, phosphorus restriction, and maintaining a bicarb of more than 22, lipid control all goes along with the KDIGO guidelines. Albuminuria, glomerular range is unlikely, and you have to look for alternate diagnosis when it happens. But few patients do present with significant albuminuria, for which AC inhibitors will do the wonder. And at the same time, tolvaptan was also found in rapid progressors for that they reduce the proteinuria independent of the effect of AC inhibitors of ARB. The hydrotherapy, which is age-old, about 2 liters, making a target that urine output reaches 2 liters per day and urine osmolality of less than 250. But the problem is you should always be cautioned for hyponatremia because of increased water intake and also volume overload when you are dealing with the stage of kidney disease, which is more than 3. There was some discussion regarding the levels of copeptin, which was a surrogate marker of vasopressin. And if the propeptin levels are low, that means vasopressin suppression is significant, but it was never translated in the clinical point of view. And the HFI inhibitors, HFI prolyl hydroxylase inhibitors have no role because it has a questionable problem of increasing cyst formation, and anemia should be always corrected and transfusions be avoided to prevent any sensitization. The other problem these patients face, which push them to an acute kidney injury and acute on CKD, is infections, cyst infections, which are very difficult to diagnose as well as treat. There can be many causes of abdominal pain for a patient with ADPKD, and whenever you have a very diffuse unilateral non-radiating pain, you should consider cyst infection when the patient is showing features of fever or toxic changes. And here, drugs which have got good lipid solubility are preferred, like fluoroquinolones and trimethoprim methazole, because these cyst doesn't usually communicate with the urinary tract, and you have to make these drugs reach the cyst through the bloodstream itself. And the problem is prolonged therapy. Almost 2 weeks of therapy is required, and for minimum. And many times you can face resistant infections because of the underdosing of the antibiotic into the pathological site. E. coli is the most common found, and it is recommended that if you have a cyst of more than 5 centimeters, be it renal or liver, and the infection is severe, just antibiotics may not be enough, and you might need the assistance of your IR team for a proper drainage. Nephrolithiasis has been always a problem for ADPKD patients. This can trigger an acute event which can push the patient into deteriorating EGFR, where the uric acid stones are the ones which are most commonly seen. And the problem is the ultrasound in checking up for hydroureteronephrosis it is usually missed when you're dealing with an ADPKD patient because of lots of cysts. The HUN may be missed by the radiologist. So always when you're feeling that you are dealing with an obstructive pattern of urethral stone, then the best modality of investigation is an NCCT, non-contrast CT of KUB. Also, hydration and correcting the metabolic abnormalities, if any, will help to prevent recurrent stone formation. And whenever a need arises, urological interventions in the form of DJ stenting, lithotripsy may be required. If there is a small role described for thiazides for patients who are having hypercalciuria, but it is still debatable. Cyst hemorrhage is another issue. Some patients can develop severe cyst hemorrhage with associated gross hematuria and severe pain. And at that time, it is best to avoid ACE inhibitors, ARB or tolvaptan if the patient is getting any. The good thing is it settles within 5 to 7 days. And a few analgesics according to the pain ladder can be tried, but avoid NSAIDs. And retroperitoneal extension, everything is rare. So the take-home message from this presentation is ADPKD is not a uniform disease. It's a mixed bag. So in a mixed bag, given the current evidences, identifying the patients who are rapid progressors are very important. And the height adjusted KTV, the total kidney volume, has been a very good prognostic marker compared to the serum creatinine that we had before. Now, treating the at-risk population with the V2 receptor, it's doubtful. We can never say because proper guidelines from the KDIGO are yet to come. It is though it's cooking, we have to wait. But this option is always open, and the evidence is relatively fair. The only thing is, while treating these patients, you can dose titrate. Treating cyst infection and hypertension, hydrotherapy, and reinforcement on the non-pharmacological measures, along with the disease-modifying agents, might be a way ahead in the future for our patients with ADPKD. That's all. Thank you.
Thank you, dear Dr. Martin, for this